Good morning. So I'm going to give you a little bit of a gist sandwich here in between the pancreas and talk about the multidisciplinary management of GI stromal tumors. These are my relevant disclosures. So the objectives I have for today are threefold. One is to describe the indications for adjuvant imatinib following GIST resection. The next is to explain the mechanisms of GIST resistance to tyrosine kinase inhibitors. And the third is to discuss the use of second and third line tyrosine kinase inhibitors for GIST. So to start off, I want to start off with a little bit of understanding about the biology of GIST. So if we look back, the interstitial cell of Cajal, or the ICC cell, was discovered in the late 1800s by a Spanish pathologist and later Nobel laureate Cajal. And these are cells that basically lie within the, between the muscularis layers of the small bowel, stomach, all the way from the entire GI tract. And they regulate and coordinate contraction of smooth muscle cells. These basically start in the esophagus and go all the way down to the rectum. And these cells express c-KIT, or the stem cell factor, several other markers including CD34, and then a calcium activated chloride channel, TMEM16A, which also goes by the marker DOG1, which is now discovered on GIST1. So there's several diseases where ICC cells are involved. There's diseases where there's low numbers of ICC cells, including chronic intestinal pseudoobstruction, Hirschsprung's disease, and diabetic gastroparesis have been implicated with this disease. And then there's diseases where it's high levels of ICC cells are present, being gastrointestinal stromal tumors. Like the ICC cells, which are the cell of origin of GIST, these express c-KIT, DOG1, as well as the mesenchymal marker vimentin. So GI stromal tumors, or GIST, are fairly uncommon. There's about 12 to 20 per million people per year in the United States, which accounts for about 6,000 cases annually. Slightly more predominant in males, and a median age of about 60 years. They typically range in people between 40 to about 80 years old. Now, historically, these have been called by many names, including plexosarcomas, GI autonomic tumors. They were often until the late 90s confused with leiomyomas and leiomyosarcomas, as well as leiomyoblastomas. As I've mentioned to you, the interstitial cell of Cajal is the pacemaker cell of the gut, and these basically are within the entire GI tract, and so therefore GIST can occur anywhere within the GI tract, but the most common place we see them is in the stomach, with about 2/3 of cases presenting there, and roughly about 1/3 of cases presenting in the small bowel. But they can, as I've mentioned, they can occur in the colon and rectum. And then there's a special group of GIST called Extra-Intestinal Gists, or EGIST, that can have been reported in the mesentery and omentum of patients. So the spectrum of clinical presentation can be very variable in these patients. They can present with just small asymptomatic lesions that present at the time of imaging for reasons. The patients can present with nonspecific symptoms, including nausea and vomiting, abdominal pain, abdominal distension, or early satiety. These things can bleed. They can bleed either intraluminally, leading to slow bleeds with anemia and melena, or they can have acute bleeds where you have either massive intra-abdominal bleeding or intraluminal bleeding. Or they can perforate, leading to fever, acute onset abdominal pain, leukocytosis. Again, as I've mentioned, these cells sit within the submucosal layers of the GI tract, and so therefore they present as submucosal tumors and don't necessarily involve the mucosa, with the exception that they can potentially develop ulcerations within the mucosal lining. But these are submucosal tumors that can tend to grow either endophytically, or within the lumen, or exophytically, meaning sort of outside the lumen of the gut. But as I've mentioned before, there are other submucosal tumors that these have been confused with, including leiomyomas, leiomyosarcomas, and schwannomas. And the real distinguishing factor between these other types of tumors that occur within the submucosal layers of the GI tract, and most commonly the stomach, is the expression of the c-KIT, or KIT protein. More looking at the biology of these tumors tend to be, they can grow very large, but they tend to push on most or other adjacent organs and rarely invade. It looks here that you can see that the left renal vein appears to be invaded here, but you can see that the tumor easily came off the left renal vein here. So these are examples where, while they appear often on imaging that they can be invasive, they're often not. These tumors also have the ability to metastasize, like